Hi, it's Dr. Centeno, running a few minutes late here, but thank you for visiting our Facebook Live today. You've got the power. Going to focus today on the PICL procedure itself and something in medicine that has been called see one, do one, teach one. So basically, going to go over, we've seen some folks trying to do a PICL procedure out there. Mostly it's physicians that aren't from the US. And that's certainly flattering from one standpoint, right? We're very happy that somebody is interested in doing the procedure. But this is a procedure that has got a lot of moving parts and one that requires extensive training to pull off safely and lots of extra equipment to pull off safely. So I wanted to go into that a little bit today. The whole concept of see one, do one, teach one. And that's something that if you're not in medicine, you may not have heard that phrase before, but it's a common thing we hear in medical school, we hear in internship, we hear in residency, fellowship, we hear that thrown around a lot. So what does that mean? What does it have to do with the PICL procedure, et cetera, et cetera? So let's see here. I'm going to go and share my screen. So we'll start with that as usual. Okay. And next we're going to go and start that. Okay, so again, today we're going to talk about the PICL procedure itself and how we keep people safe. And while we've been seeing a couple offerings outside of the US sort of pop up, every time I see that, I kind of do one of these, raise one eyebrow and go, what? What is that guy talking about? What are they doing? Which is really why I wanted to talk about this today. So let's go over first this concept in medicine of see one, do one, teach one. So when I was in medical school, and I think this is still used today, we would have this concept of see one, do one, teach one. And what that basically means that in medical training, medical school, internship, residency, fellowship, the concept is that usually what happens is that you watch an attending doctor or a resident physician, depending on where you are in the food chain, so to speak, do a procedure. And then you're supposed to, from that, be able to do one yourself with the resident or whoever your instructor is or attending observing you to make sure that they can say, yeah, you're doing that correctly. And then fairly rapidly, you're expected to teach others how to do that procedure. So hence we have the see one, I've seen one done, do one, I did one, and then pretty quickly, I'm teaching how to do that procedure. Now, for procedures like lancing a boil, as you might imagine, that pretty much works. It's not that complex. But obviously, it has its issues. So on the right here, I've got all these different lawsuits that have been filed against big universities. And usually, it's the see one, do one, teach one where they get into trouble, right? They've got residents, interns doing things that they probably shouldn't be doing. And maybe these things are more complex or they take a little more thought. And there's big problems that happen because you tend to have less experienced physicians sort of running the show and the attendings are kind of managing the show rather than doing all the different things. Different from private practice usually where someone is already a minted physician, has done training, and they're the one running the show, so to speak. So for the past really 1 to 2 years, couple of years, we've had several ex-US physicians kind of trying to replicate the PICL procedure, and they're certainly using the see one, do one, teach one technique, right? Since I haven't actually trained any of these physicians to do these procedures, the best they can do is to watch one of these videos or one of the videos I have online and see, yeah, you do that, you do this, okay, I get that, etc. So it's very much see one, do one, teach one, meaning they most of them haven't even seen a real PICL procedure. They really just see one through watching a video, and next thing you know, they're giving it a shot. So most recently, there was a physician in India who was doing this. And I want to kind of explore today what's necessary to do the procedure safely, and so that you can understand why see one, do one, teach one doesn't really work for this. And in my mind, some of this stuff can get pretty dangerous with regard to some of these foreign offerings for PICL. So I'm going to go through what constitutes a PICL procedure. And the first that we have figured out through much trial and error is dual C-arm guidance. And that means, and as I'll show you, we've got two C-arms set up at the same time. Can you do it with one C-arm? You can. The problem is it just reduces accuracy, and reducing accuracy has some consequences. You also need digital subtraction angiography on your C-arm. I'll go through that. You got to use contrast. So for instance, there was some discussion that this Indian physician who said he could do this wasn't using any contrast. Why would that be? What are the risks involved with not using contrast? What is contrast? A 3D printed mouthpiece. We've created several different types. And that's another critical component here, because you've got to be able to x-ray through that thing. Using an endoscope so you can see what's happening at the back of the throat, and you can maintain that sterile field. How the bone marrow concentrate is harvested and then processed is also important, because we need it to be hyper sterile, because we really don't want infections in this area. And you've got to have extensive interventional spine training, and then obviously extensive hands-on proctoring. So dual C-arm guidance, in this picture from the procedure room where I do the PICL, and usually where we do all PICLs. You can see here that we've got two C-arms labeled 1 and 2 here. So that means that one C-arm is giving us this front view, and the other C-arm is giving us the side view. And what I've found is this dramatically improves the targeting of specific structures. And it also helps to safely avoid some of those catastrophic injection areas. So for instance, you wouldn't want to put the needle too far forward, because you can end up in the spinal canal, for example. Having this real-time imaging in both directions helps to do both of those things. Digital subtraction angiography is a really big one. This happens, so what DSA is, DSA allows you to highlight if a vessel is picking up the contrast. So you got to have contrast to make DSA work. And in particular, if you're doing C0, C1 injections on the patient, which is very common in the CCI population that we treat, you've got to make sure that you're not in that vertebral artery. Same thing with C1, C2 injections. And the way to do that is to use digital subtraction, because it'll highlight if you're in that artery. And the reason you don't want to inject into that artery is you can stroke the patient out. And so not having DSA obviously is a pretty big problem in this case. You obviously need to use contrast, and I can't stress this enough. Now, it turned out that this Indian physician had told someone that he wasn't using contrast, and that's not atypical for what we've seen outside the US. It seems funny to us here in the United States that someone wouldn't use contrast. So what is contrast? Contrast means that when I do an injection under X-ray guidance, I can use a substance that can be seen under X-ray guidance to see exactly where that injection will go. That's for both confirming that I'm in the right spot and the right ligament. And that's also to try to make sure that I'm not in the wrong spot. I don't want to be in a big artery where I could stroke out the patient. I don't want to be inside the spinal canal or inside the dura or epidural, all of those things. And this allows me to stay away from those spots. So as we talked about during that 0-1-1-2 injection, that's pretty critical to avoid the vertebral artery. Even in the PICL procedure, we see little arteries. And when we see that, we move elsewhere because we don't want any of the stuff we're injecting going into those little arteries because it could block them. In addition to that, a very common thing, it happens maybe 1 in 3 to 1 in 2 times, we end up in a bursa or a lubricating sac. And if we're in a lubricating sac, it's not going to do much good because we're not in the ligament. So we really, really need contrast in a PICL. So doing it without contrast, there's just no justification for it. But why would that happen in some places like this Indian guy or elsewhere? Well, we often see that as funny as it sounds to US ears, US medical ears, that there are turf wars within many of these foreign hospitals where if you start using contrast and x-ray guidance, you get into a turf war with the radiology department because only the radiology department is allowed to use contrast. And that sounds super silly to any US physician because that generally wouldn't happen here because in the United States, we've got lots of malpractice things going on here. And if you don't use contrast, it'll be considered malpractice for sure. In the ex-US, less malpractice and these turf wars, so it sometimes happens that way. But there is no way to safely do the PICL procedure without radiographic contrast. Another thing is 3D printed mouthpieces. We'll see some of these guys trying to replicate a PICL ex-US, use these metal clamps designed for ENT surgery. The problem is that's going to block your view of all the things you need to see to stay safe and to target specific ligaments. And the only reason we did these 3D printed mouthpieces was simply because we need to be X-ray through that device so that it wouldn't block the view. And there just weren't any of these around. These ENT pieces of equipment or devices are out there, and there are ones that can depress the tongue, but they're going to block the view of what it is you need to see. So if you're using an ENT device, and all of the foreign PICLs I've seen use these metal ENT devices, you're by definition doing a suboptimal PICL because it's blocking some of your views of where you need to see to do the procedure accurately and safely. You also need an endoscope. I haven't seen anyone using an endoscope outside the US. The few people that have tried to do this, that allows us to see the back of the throat so that we can really maintain the sterile field. That's the biggest thing with an endoscope is it allows you to very accurately say, I've defined the sterile field here, and I can't stray out of that area because otherwise I'm not sterile and I may introduce bacteria. Or let's say the patient decided that they didn't really want to adhere to some of the restrictions we have about eating or drinking before the procedure, and they bring up a little stuff from their stomach during the procedure. You have to be able to see that, and you can see that with an endoscope because you're seeing what's going on at all times, but you can't do that just kind of peer it in there periodically. So again, this is a sterility thing that's very, very important for us. And this procedure can't be done without an endoscope. But again, ex-US, this gets into procedure and turf wars, right? Endoscopy is usually only used by ENT and GI. And obviously that's not the kind of doctor that would do this procedure. So my guess is it would be pretty hard in many ex-US hospitals to even get a hold of an endoscope. So that's another issue. We also need to make sure that what we're injecting, in our case, the bone marrow concentrate, is hypersterile. So that means that the bone marrow aspirate is taken via a full surgical prep. And that full surgical prep is the most sterile way to do it, meaning it's a lot more sterile than just using a little bit of alcohol and taking some blood for PRP, for example. And that once that stuff is processed, it's not just processed in a little bedside machine that's kind of off to the side on a shelf in a room, but it goes into a CGMP class laboratory where all of this is done under ISO 7 hoods and ISO 5 hoods and an ISO 7 environment, so that it is hyper sterile from the beginning. It's taken from the moment it's taken out of the body to the moment it goes back into the patient. And again, No one else has this capability outside of Colorado. There's no one else on earth that's got a CGMP class clean room where this stuff is done. Just doesn't exist outside of Centeno-Schultz. Obviously, we also want anyone we're going to train this way to have extensive interventional spine training. And I think I've used this example before. Out of about the 10,000 interventional spine physicians that are trained and certified in the United States, only about 100 or more would have injected the 0-1 joint, for example, more than 100 times in their career. So we've gone from 10,000 to 1% of those providers. And then of those, there's no one that I know of that's done that procedure a couple hundred of times. Now, why would it be important to do it hundreds of times? Because you don't really get good at something until you've done it at least hundreds of times. It's just the way it is. I don't care if you're a doctor doing something or it's jumping on a trampoline as a kid. You don't get good to it, and you don't get good at it, and you don't get mastery of it until you've had lots and lots of repetition. So again, there's not even many physicians out there that we could check off the box and say, yes, this person is in that category to start doing this, because they just don't do this procedure enough. And that would be the minimum necessary to train to do PICL. And then finally, you've got to have extensive hands-on proctoring with the inventor of the procedure. When Dr. Schultz started doing these procedures, he was observing me through the first several hundred, meaning he was at every single case. I wouldn't allow anyone else to do the anesthesia other than Dr. Schultz. Dr. Schultz is a board-certified anesthesiologist. So he got proctored through hundreds of cases watching me do the procedure when no one else was doing the procedure. And then Dr. Pitts has had extensive proctoring within our clinic. And there's no one else on earth who's had any of that proctoring. Now, we will go ahead and start training a 4th and 5th position at Centeno-Schultz this year and next year. And the reason for that is trying to make sure that once I retire and once Dr. Schultz retires, we have some bandwidth available to be able to accommodate patients that need this procedure. But that's, again, going to be through many, many cases of hands-on proctoring. It's not going to be see one, do one, teach one. It's going to be watch lots and lots of these, have me proctor you on lots and lots of these. Even once all of that's happening, interface with me on who's the appropriate candidate, who's not the appropriate candidate, etc. So there'll be a lot that goes into that training, much more than we see with some of the other procedures we offer. So in summary, the PICL procedure is not a see one, do one, teach one scenario. And in my opinion, any physician who's watched the video or maybe watched me perform this once that tries it is really being irresponsible. This is the hardest, most technical procedure I've performed in my career. And that's saying a lot. And it requires specialized equipment and training to do it accurately and safely. And I do want to make sure my colleagues out there understand this. I won't be responsible for a see one, do one, teach one doctor severely injuring a patient, meaning, I've said it many times on this show, and I'll say it again today. If you're a doctor out there that wants to do this, you're going to have to jump through all of my hoops to be able to get to do it in real patients. And if you're just watching a video and trying to replicate it and you hurt somebody and they come to me as the expert on that case, it's not going to be pretty, because this is not a see one, do one, teach one scenario. Okay, let's go to questions. Looks like we got a bunch of those. Let me stop the sharing so we get out of that. And we will go to try to answer as many questions as I can here. Hey, Doc, have you gotten a chance to speak to Dr. Casper on the overhang case study with healing chronic patients? Yeah, we did talk about that. Those patients tend to be more acute. Realize that Dr. Katz has patients who are not infrequently getting diagnosed very, very quickly, right? Meaning that Dr. Katz does probably half his cases are or more in that acute setting. They've just had a car crash. They went to the ER. They're coming to see him for that first round of care. So I think that's the biggest difference there. It's very different than our practice, where it's very uncommon for us to see an acute patient. It's much more common for us to see patients that are in that chronic category. Every once in a while, we'll see patients within that first year of injury. But I think that's the biggest difference there. AT, your thought process in scenarios where majority of DMX overhang appears in end range versus majority appearing in mid range. Yeah, I don't. So when it comes to overhang, I don't think there's much movement that's allowed, period. So if you've got more than 2 or 3 millimeters of movement, that's a ligament thing. Now, I think what you're describing is that if you've got a ligament injury, and let's say if I really push you to the side, I can get 6 millimeters of overhang out of you. Realize that person is going to make an attempt to try to stabilize in the mid-range, but eventually we'll see what the ligament can do by canceling out that muscle component by really pushing the patient. So I don't really think that what we're seeing there is the difference between a muscle or a ligament issue, because the ligament shouldn't allow more than approximately 2 to 3 millimeters of overhang anyway. Now, if all we're seeing is 2 millimeters of overhang and they don't get that until they're way over, then I would agree with you. We're really seeing more of a muscular issue than we are a ligament issue. But if we're seeing 6, it's in a different category. Yamas, doing better but needs multiple treatments combined, 3 PICL. Great, good to hear. Bo, after PICL, when do you recommend have NUCA check the vectors and how often? Yeah, Bo, so I think it's always a good idea if you're seeing a NUCA chiropractor and you were seeing one before and you were doing well with it but only had temporary relief, so that's the caveat. And then afterwards, I don't think they necessarily need to check the vectors soon, but at around that 3-month mark, it would probably be a good idea. Or you can just go through NUCA, and if you find that it's no longer working like it used to, that's really when I think checking the vectors becomes important. AT, it's impossible for a joint like C0, C1, for example, to be locked on one side, and that attributing to greater hypermobility of the entire joint overall. Yeah, I think we talked about this via email. And I think the answer is mostly, I think if that's happening, you're going to see muscular spasm that causes one part of the joint to lock, and then the other is hypermobile. I don't think you're going to see an area of hypermobility, for instance, in the front capsule, and then an area of hypermobility in the back capsule. I think it's mostly suboccipital muscles there. I don't think that next question is for me, so I'm skip that one. Hello, doctor. I'm fasting from sunrise to sunset. Is that bad or good for a CCI patient? Listen, I think if you're just doing some intermittent fasting, or if you're doing fasting for Ramadan, I think that's fine. It's my understanding, for instance, for Ramadan, that you then eat at night. So I don't think that's going to really cause a problem. If anything, it might help a little bit. Intermittent fasting can help reduce systemic inflammation. So I think that's probably a good thing. AT, what are the negative effects of forward anterior thoracic spine curve positioning in relation to the C-spine? Deed Harrison has some good research in this area. Yeah, I think it's a problem. We see, we've got this generation, right? So this generation is constantly doing this, and as a result, they end up with thoracic kyphosis at a much higher rate. Thoracic kyphosis means forward head, forward shoulders. And that's putting a lot more pressure on the upper cervical spine, and it's also putting pressure in other areas of the cervical spine as well. So we're seeing many, many more people end up with many, many more neck problems because of that. So recognizing that that's happening is something I talk to a lot of patients about. And I would agree, Deed Harrison and some of the CBB provider research done by the Harrisons is really quite good at looking at the impacts of that and looking at the clinical benefits of getting rid of those issues through curve correction. Hajar, I did all measurements on my MRI and CT scans. The results doesn't show CCI, but I have almost all CCI symptom. How is that possible? Yeah, Hajar, MRI and CT scans would be the least sensitive way to show CCI. So if you've got CCI and you have an MRI or CT scan, while your MRI or CT scan could show why that's happening, could show CCI, it wouldn't be the most sensitive way to show CCI. So it's certainly possible, for example, that you have CCI, but you would see it, for instance, on a digital motion X-ray, but you would never see it on a CT scan or MRI. So be a little careful there because you're looking at studies that are the least likely to show it if it's present. Ryan, what are some causes of sharp pain in the mid of neck and the spine, especially when tilting head back? Heard it can be loss of curve. What could be happening here? Yeah, Ryan, so we certainly see loss of curve can play a role in that. So for example, I'll do a test where I'll put my hand or my fingers right in the middle of the cervical spine, and then I'll have the patient extend. So the first the patient will be asked to extend their neck and look up. Yes, that hurts right there, doc. I'll put my hand here in the middle, support the lordosis as they extend. And then many times the patients will say, oh yeah, that pain went away. Then we know it's loss of curve and I know where to send them, right? Now, that can also happen due to a facet joint that's been injured. Because you're loading the facet joints there, so an injured facet joint is not going to be happy in extension. Yamas, any improvements on the PICL procedure? Yeah, we just sort of went through another round of improvement. Listen, I do most of these days, so I've been doing improvements. One of the big improvements we've just added in this last probably 6 to 8 weeks is a more accurate way of getting into the alar ligaments that involves a sort of counterintuitive way to direct the needle relative to where the ligament lives. That's about all I can say about it, but it's dramatically improved alar ligament targeting, and it's dramatically improved. I think it's going to dramatically improve results up another notch as well. Now, that's something that I've relayed to my colleagues, Dr. Schultz and Dr. Pitts, but this is a procedural adaptation that I made in order to improve the ability to target alar ligaments. And it's made a huge difference. So hopefully that's going to also make another bump in improvements in the procedure. So pretty exciting, very different procedure, approaching it a different way than you would normally approach it as an interventionalist, but it's made a tremendous difference in getting into those ligaments much more accurately, and not only much more accurately, but much more thoroughly. Caleb, have you found dextrose prolotherapy to be a good long-term solution for EDS? Isn't there a possibility the ligament can loosen it out again in fragile patients warranting booster treatments? Yeah, Caleb. So yeah, dextrose prolotherapy works really well for hypermobile, for most hypermobile EDS patients. Now, obviously, there are different genetic variants that we don't fully understand. But my first experience with this, and I think I've told this story before. My niece, super smart woman, ended up getting a full ride scholarship to Princeton, and then got a scholarship to Cambridge. Finished out Cambridge. She's got hypermobile EDS, but a very rare variant, and dextrose prolotherapy would work wonders for her. Now, is it possible that you might need booster treatments? Yes, that's certainly very possible that you might need booster treatments. But dextrose prolotherapy can be very effective in that crowd. Another thing that we commonly see is that bone marrow concentrate or bone marrow treatment tends to work better than dextrose prolotherapy. And it seems both of those seem to work better than PRP into the ligament. And we're not quite sure why, but it may be that both dextrose prolotherapy and bone marrow concentrate are much more inflammatory than leukocyte-poor PRP. Caleb, if PRP is only twice as strong as Prolo, in the case of moderate SI joint laxity, wouldn't it be more cheaper, better to get 4 to 6 Prolo treatments instead of 2 to 3 PRP treatments? What's the cost offset of something like that? Maybe. Yeah, sure. I guess it depends on how expensive the PRP is, what concentration the PRP is, et cetera. That's really up to the patient and how price sensitive the patient is relative to getting results, right? If I tell lots of patients that they're going to need to come back 6 times, if they're local, that may not be a big deal, but for some of them, they don't have 6 times to get off of work, to get someone to take care of their kids, et cetera, et cetera. So it all depends on the patient, but it could be. Regenetics Mid Advanced by Christy Mader for patients trying to improve stem cell counts part of the PICL. Do you recommend a low-carb diet? Wondering if it's the glucose spike and our insulin response from carbohydrates that affects stem cell counts, actual carbohydrates themselves reduce stem cell counts. I don't think it's going to reduce stem cell counts as much as what it will do, I think, is to damage all of their cells, let alone stem cells, including their stem cells. So that their stem cells may not be as functional if they've got hyperinsulinism versus someone who has no blood sugar control problems at all. And so I always tell patients, if you are like most people, right, you've got into your middle age and you've started to gain weight and you got that middle age paunch, then going on a low carb type diet before any of these orthobiologic procedures is probably a good idea to reduce that hyperinsulinism that goes with that metabolic syndrome. Bo, I've been having numbness and nerve pain in my limbs when lying down. Is this common with CCI? Do you think neural therapy injecting procaine can give relief while I have a few months before PICL? I doubt neural therapy is going to be all that effective in that kind of situation. A lot of it depends on why that is. So, for example, we see a lot of patients who we do PICL on, for example, that have a big old bulging disc, and that's causing what it is you're describing. Sometimes they don't have a bulging disc in the lower neck. Sometimes it's just there's so much motion at C1, C2 that they're getting dural irritation higher up. But I don't think that neural therapy is probably going to move the needle there. Human being, I wanted to add that Postural Restoration Institute, which is reliant on cranial osteopathy, has producers in the U.S. come up with recognizing cranial distortion and malocclusion. Gotcha. AT, importance of rib cage positioning to pelvis. My CBB provider has found it shifted 25 millimeters backwards relative to the pelvis and is treating, but curious relation to C-spine. Sure. Yeah. I mean, all of that is the foundation of the house, right? You know, we would all know at face value that if the foundation is unlevel, then the walls are going to be all screwed up and the roof is going to be all screwed up. Same thing in the body. If the foundation here in the rib cage is left, right, up, down on this side, rotated forward, back, it's going to have an impact on what's going on in the neck. Regenetics been advanced by Alice Moore. Dr. Centeno, have you ever heard of Biograph scaffolds in place of knee replacements? Thanks, Alice. Yeah, I think what you're talking about there is usually some sort of amniotic or umbilical cord. So umbilical cord Wharton's jelly, amniotic membrane, for example. That could be helpful, but it would depend on the severity of osteoarthritis. And if you look at where the research is, you'd have far more research, for example, that PRP is very, very helpful in moderate knee osteoarthritis than you would for any, quote, Biograph scaffold. So you'd want to go where the evidence is, and that would be with high-dose PRP at the moment. Ryan, is there specific supplements not to take, say, a month before PICL? Biggest one I think we've seen issues with potentially is fish oil. So for fish oil, you're going to want to make sure that you're off of that for a good 2 weeks or so before your PICL procedure or any procedure involving the spine for that matter, because it can increase bleeding times and it acts to thin out your blood. And that's not, while that can be managed, it's not something that's good for any kind of spinal procedure. Kimmy, I just had my first PICL with you Wednesday, looking over procedure notes. Could you explain what exactly hydro the vagus under the SCM does? Yeah, so all that means is that we're doing hydrodissection underneath the sternocleidomastoid, and that we've done that hydrodissection both to help the nerves that come out of the back of the sternocleidomastoid and the nerves that midline go underneath the sternocleidomastoid, and that would include the vagus. Noose, good evening, doctor. I live in Morocco. I suffer a lot. Can you guide me to relieve my pain, dysautonomia, tethered cord? Certainly happy to do telemedicine, and that's where we go through everything, your imaging, your history, your past medical history, what you're having now. And as people will tell you on the Facebook group, there's lots of times during the telemedicine that I can make specific concrete recommendations to try to help, but certainly not here on a social media platform. Regenix, it's been advanced by Sherry Scott. Shouldn't there be rules in the medical field to prevent doctors not being properly trained, not using correct equipment and procedures? Yeah, that's an interesting one. The answer is there are some, and I can only attest to what those rules are in the United States, right? We have, lots of things in the United States that provide some walls there, but not always. So for example, you have to report to your medical board, and your medical board can censor you, take your license away if it thinks you're practicing out of that scope of practice. Then there's the malpractice system, and that malpractice system is another way that kind of keeps doctors in their lanes. And then a third system is many times if you're working within a hospital, they'll require certain certifications. But if you're not working in a hospital, then that doesn't really apply. So just realize that, yes, there are, but even in the United States, where that's probably the strictest, you still get people kind of operating outside of their lanes, especially more recently in the last 10 years than you would see in the 10 or 20 years prior. Regenix, been advanced by Harry Winston. What would the recovery period be before it say fly back to the UK? Yeah, Harry, if it's your first PICL, we would definitely recommend that you spend a few days here. So I often tell patients, come in on the prior weekend, get your procedure done early in the week, let's say Monday or Tuesday, stay the rest of the week, go home the following weekend. Now, once you see what your response is going to be and you have some idea of which end is up, let's say you need to come back for a second procedure and everything went very smoothly, then obviously you can shorten that by quite a bit. But for the first time, it's always best to have the ability, let's say you need to be hydrated. We had a patient that came into the office today. She had kind of known that she was dehydrated, wanted some hydration. We just took her up to some IV fluids. The office communicated with me. And everything sounded like it was heading the right direction. That person just needed hydration. So that's always good to have that option. Another reason for that here locally is we're at altitude, right? It's very dry here compared to many places that patients come from. Barbara, when is Dr. Williams leaving Atlanta? Will be any rejection providers in the metro Atlanta area? Yeah, Barbara, we do have other Regenix providers in the metro Atlanta area. If you just go to the Regenix website and click on that Find a Provider, you'll see those. It's my understanding, I don't want to speak for him, but it's my understanding that he'll be transitioning down to Grand Cayman starting this summer. And even that's going to take some time. So I suspect that he'll be available through most of this year would be my guess here and there. But that's something really to bring up with Dr. Williams. I don't want to steal any of his thunder there. That's just based on what I have found out in communicating with the Cayman Clinic and seeing how that affects everything that we're doing. Brian, in your recent article on repeat PRP procedures, seem to include there is a diminishing return with repeat injections, making perhaps not worth the money. From insurance perspective, correct? If the cost not a barrier for the patient, or repeat injections still worthwhile? Do you ever see outstanding results from any treatments in the same area? Yeah, Brian, that was in particular, that blog was in particular focused on knee osteoarthritis. And what I didn't see in knee osteoarthritis was a huge difference between multiple PRP procedures, let's say 3 in the same knee in rapid succession versus a single one. Now, there was some offset there, but the offset was relatively small. So for 3 times the cost, we didn't really see 3 times the effect. And that was really that discussion. Now, that's quite different than in many situations where, let's say, we're treating a loose ligament, where sometimes multiple treatments are needed to get the ligament to fully heal. That was more a degenerative issue like chronic knee osteoarthritis. L. Akhtar, doctor, how do I test for EDS? What doctor should I see to test it? I think the simplest, easiest thing to do, even though it's not 100% accurate, is to look up a Beighton score, BIEGHTON score, or it might be BEI. Don't hold me to that. I think it's BIE, I before E, except after C. But look up a Beighton score, and that's a quick test that you can find online, lots of videos on how to perform it. You can get a quick score. It'll give you some idea of where you are in that hypermobility spectrum. But it's something you can do at home. Lots of videos out there on how to do it accurately. Noose. I sleep with a soft collar. Otherwise, my head deviates to one side or forward with pain during the day. I also use a semi-rigid or soft collar a lot. Is it dangerous? Yeah, Noose, the biggest issue is just that, the more you use the collar, the weaker your muscles get. And muscles are required as one element of stability. So you really don't want to use a collar very much. I often tell patients, appropriate collar use might be, I know that going in the car usually whacks out my neck. I've got a 20-minute car ride, so I'll use the collar. Or I know that traveling in a plane or going through airports whacks out my neck. I'm going to wear a collar for just one day as I go through the airport. Or when I do X activity, I only do that X activity 20 minutes a day, I'll wear a collar 20 minutes a day. Those are pretty reasonable uses of a collar. But if you're wearing a collar for most of the day, it's a two-edged sword, right? It's going to help on one side and reduce symptoms, but it's going to hurt on the other side by making the muscles weaker and reducing the range of motion. Ryan, you mentioned CCI patients have hard time maybe doing curve restoration before getting treated. After getting treated, is process for curve restoration, is there any treatment or all exercise based? Yeah, Ryan. So I always tell my CCI patients after their PICL is a really good way you can see if you're ready for curve restoration is to take a towel, small hand towel, roll it up to a specific thickness. You can experiment with making it thinner or thicker. Put it right back here in the middle of the neck. Lie face up on a hard surface and see if that feels good. And most patients are going to bifurcate into 2 categories there. One where they're like, yeah, that feels really good. It feels like I need more of that. Or, wow, that really whacked out things for a day or a couple hours. I shouldn't do that again. Obviously, if you're in the this feels really good category, then you're ready to start doing some gentle curve restoration. So that's what I tell my patients. AT, after PICL had some improvement, now able to do CBP and tolerate it. Coming back to the last, but slowly progressing for many months, better to down that road, even if it means giant gap between getting a second potential PICL. Yeah, so AT, I think what we found was, I think I've talked about this before, during COVID, we kind of had a natural experiment, right? We had some patients that weren't able to get back in for a year or more. We had about half of those patients regress, half of those patients kept their gains. So my sense would be, I don't know, it's 50-50 about prolonging the second PICL. But you and I have been in communication a lot about that. So I think we got a pretty tight handle on that. And so happy to keep going back and forth with you via email on at what point is a good time for you to pursue that second PICL versus just doing more of what it is you're doing. Valerie, does having osteopenia cause complications for harvesting stem cells from the bone marrow? Also, can osteopenia cause any healing issues related from BMC or PRP injections? When it comes to mesenchymal stem cell density, it may mean there's a lower mesenchymal stem cell density. Now, we're adjusting for that, knowing the dose of total nucleated cells. So it shouldn't be a problem if you've got osteopenia. But it is something certainly to discuss with your doctor, so your doctor knows to be on the lookout for a possible dosing issue and adjustment. Sky, 2 questions on cervical medullary syndrome. Would symptom of numbness, weakness, or shooting pain through shoulders be requisite for diagnosis? Not necessarily. It's certainly not true that numbness, weakness, or shooting pains through the shoulders diagnoses cervical medullary syndrome, because there's 20 other things that cause that. Can people with cervical medullary syndrome have numbness, weakness, or shooting pain through their shoulders due to the cervical medullary syndrome? They can. But be really careful with that, because there's lots of other things that cause that. And what I see a lot of patients do is they get down this specific rabbit hole of going down a diagnosis and then saying all of my stuff has to be related to that diagnosis. And by doing that, they tend to reduce the chances that they're going to get help, because there are more commonplace issues that can explain why they have the problems that they have, and they're skipping over those diagnoses. So another big one I see all the time is tethered cord, right? They're on this whole occult tethered cord thing. They've watched the videos. They're like, I've got a occult tethered cord. Why? Well, I've got back pain. Okay, there's 55 causes of back pain. Why do you think this one's related to occult tethered cord? Well, I got CCI. Okay, well, most of the patients I see with CCI that have back pain have an independent back issue. We treat that back issue, their back pain goes away. So it's unlikely that occult tethered cord has anything to do with your back pain. Well, I've got urinary symptoms. Well, it's pretty common for people with chronic back pain, especially certain types, to have urinary symptoms. So again, those usually go away when we treat the back. So again, you see they're going down a certain rabbit hole called occult tethered cord, and they're totally missing what the real cause is of their problem. And that rabbit hole is reducing the likelihood that they're going to get better, not increasing it. Jolene, what variant of EDS does your niece have? What works for classical EDS? Yeah, thankfully what she has is extremely rare variant. I don't want to talk about her medical history beyond just in general, but she's got an extremely rare variant. And she knows that because she's had a full genome done. Why? She was a PhD student at the time at Cambridge, and that was one of the bennies of being a PhD student at Cambridge. They would do your whole genome. So she knows exactly what she has, very different from most people who don't get whole genome testing. As far as classical EDS, the good news is that classical EDS patients respond in a very similar way. It's Prolo works well, PRP for their ligaments not as much, bone marrow works really well. Rhymes, hey doc, what seems to be the problems with intertransverse ligament injection? One of your articles present the DSA as must-haves. It's safe to inject on the side. Well, if you're talking about cervical intertransverse ligament, the vertebral artery runs right there. So you wouldn't want to do that under anything where you didn't have digital subtraction angiography. You certainly wouldn't want to try it under ultrasound guidance, because there's no clear and easy way to make sure that you're not in the vertebral artery under ultrasound. You would want to do it with X-ray guidance using digital subtraction angiography and contrast to make sure you weren't in that ligament. What could happen, or in that vertebral artery? What could happen if you inject the vertebral artery? You could kill the patient. So not a good day. It's a bad day for everybody. News, can TMJ cause CCI or AAI? No, it's usually the opposite. We usually see a lot of CCI and AAI patients develop TMJ because they start using all of these anterior strap muscles and overload their TMJ. So usually not causative that direction, but the opposite direction. Sky, would detectable change in CSF flow at point of spinal compression MRI be requisite for diagnosis? I think you're referring back to CMS. My understanding is that MRI is the applicable tool to evaluate CSF flow. Yeah, I mean, certainly helpful as a piece in the puzzle, right? Imaging very rarely tells us specifically what's wrong with somebody in isolation. More commonly, we will see imaging as something that's helpful in making an overall diagnosis. So if we see decreased CSF flow in a CSF flow study, right, where the DENS comes back towards the spinal canal or the medulla there, that's very helpful. It's another piece of information. Now, it's just one piece of information of maybe 10 with history, exam, provocative maneuvers, etc., that you'd want to see to make that cervical medullary syndrome diagnosis. Sky, thanks so much for spending time with patient education. Sure, always happy to say, as you guys know, I really feel that getting out here as much as I can, answering questions, helps people learn. And the more people know, the more likely it is they're going to be able to get better, especially in this world of craniocervical instability, where it's really hard to find providers that can diagnose it, that can treat it, and it's even harder to provide anyone who will answer any questions. So always happy to be here and try to help. Light Hope, is it possible to have PICL procedure conducted with initial provider perform the treatment? Can subsequent procedure be scheduled with another qualified provider? Not sure what you mean by that one. Maybe is the provider that you do your telemedicine with the same one that you do your initial eval with, the same one you do your PICL with? The answer is that should happen that way. And if you're doing a subsequent PICL, you'd again probably want to be with that same provider because that provider is going to know the most about you. Now, might there be situations where something happens, this huge snowstorm or something, and you can't come in one day and you get bumped to someone else's schedule in my clinic just to try to accommodate you so you don't have to not do your PICL after spending all that money on traveling. Yeah, that could be possible, but that would be super rare. Hajar, is CXA level 135 mean CCI? No, does not. We start to get concerned about CXA when it goes into the 120 range. So 125 and below, 130 and below, start to get a little concerned. But 135 and below does not mean CCI. In fact, that was just studied on the recent Nicholson et al. Paper. That would be a normal finding on the Nicholson upright MRI paper. So you have to be careful there. But again, it's a clinical diagnosis. So imaging is one part of the diagnosis. It is not, and I repeat that again, does not make the diagnosis by itself. 98% of the time you can't do it that way. And if you do it that way, you're going to end up with a lot of people who don't have the problem, but are getting the treatment anyway. So be really, really careful with that. Light Hope, can subsequent PICLs be scheduled with provider? I think I got that one already. Hajar, what is your advice for CCI patients who couldn't afford PICL? What should we do until we get the treatment? PT exercise, anything we do at home that could help us? Yeah, I think the best next step is a telemedicine evaluation. I can usually give people advice based on the whole picture of what I've seen. And as many patients will probably tell you that have been through my telemedicines, I'm frequently able to say, maybe you should try this, maybe we should try that based on what the local resources are. Caleb, how often do you see injectate leaking the epidural space during the facet injection in middle-aged individuals? Yeah, it depends on level. For instance, it is super duper common, almost always at C5-6, 6-7, or 7T1. A bit less common at 4-5, very uncommon in the upper cervical facets. Caleb, for suboccipital muscle attachments, tendons onto the occiput, can dextrose be used? It can be, yes, used. I think the only thing you'd want to be careful about with hypertonic dextrose there is making sure that you didn't inject into one of the occipital nerves, because that could damage the nerve. Krissa, should Botox for migraine be avoided for CCI patients? Yes, in general, Krissa, the problem is that Botox works by making the muscles weaker, and most of our CCI patients need as much muscular stability as they can possibly get. So the answer to your question is I would avoid that, because you're kind of going the opposite direction that you need to go. Brian, do you have any knowledge of BRTX trial status? From what I saw in infographics they posted, the results were not stellar. I'm concerned their management is quite irresponsible. Oh, yeah, I don't know. I didn't really see anything about their most recent trial results that looked not stellar to me. I think all they were doing was an early phase 2 trial, phase 2A, if I recall. So it's kind of more about trying to get to safety, meaning they're not really focused on efficacy in a 2A. So maybe that's what you saw. John, have you treated multidirectional shoulder instability where the patient is able to dislocate their shoulder out of place by themselves? Yeah, we treat a lot of those patients, and they do pretty well with regenerative medicine. I think the biggest thing to make sure of is that there's not major tears in the joint capsule. Usually we can see that under ultrasound, but assuming the joint capsule is still mostly intact, yes, that's been done. Or patients do well with that. Sure, happy to help, AT. Hajar, doctor, what's the solution for trouble swallowing, fatigue, diarrhea? Yeah, so Hajar, like I said before, best thing to do is to start with a telemed. Valerie, I'm in the UK. It's better to get an upright MRI than have first telemedicine call about possible CCI. I should arrange a call for you first and determine what scans, tests are needed. Listen, Valerie, if you can get a flexion extension upright MRI, I think that'd be fine before a telemed. And there's really not too much else we can do in the UK as far as getting additional testing. So I think it's okay, but just make sure that your upright MRI has full flexion and full extension. Those are the most important views for us to see. Hajar, how common does CCI cause body scoliosis and pain on one side of the body? It's not uncommon that we'll see some scoliosis being caused by the CCI, meaning abnormal proprioceptive input from the upper neck. Aaron Joe, would you recommend PRP injections for CCI patients, tachycardia, possible jugular vein compression, fibrillation issues, and fibromyalgia? A lot of that's going to depend on what type of CCI you have. There are, depending on how we look at it, 8 or 9 different subtypes. Each one of those subtypes maps back to ligaments that need to be treated. So you got to get an accurate diagnosis on the CCI subtype before you could answer that question, or before I could. Frankie, having pulling behind my eye and crunching in my upper neck with even the smallest movement, what is that sound? Why am I dizzy and getting surges in my occipitals? Probably the 0-1 joint would be my guess, but could be lots of things. Hard to answer here in this kind of setting. Sean, if someone were to have some form of DDD in the lower cervical spine, is there an orthomodulate solution to this? Yep, we treat it all the time, all day long and twice on Sunday, as the saying goes. Noose, can CCI or AI change body posture with scoliosis, coxarthrosis, knee arthritis, body pain on one side with large spasm? It can certainly put more pressure on one side, which can cause issues. Cheyenne, Dr. C, can glossopharyngeal nerve be treated, and what would indicate it needs treatment? It can be treated. Mostly the biggest thing we see with glossopharyngeal nerve issues is pain at the back of the throat. That's a big one. Or hypersensitivity at the back of the throat. Usually it's being pinched by the instability, usually C1 or C2 transverse process, banging into or messing with the glossopharyngeal nerve. Treatment is usually just fix the CCI. Munit, my pain has moved from the bottom of my end to my jawline. Feels like TGE ligament. My jawline hurt. I don't know what bottom of my end means, so I can't answer that one. Cheyenne, context is very bad, one-sided throat, ear, and sometimes partial tongue pain where C2-3 is misaligned or flared up. Yeah, so probably more just intermittent compression of that glossopharyngeal nerve. So the best way is to treat the instability. That's usually the direction to head. Ryan, for unexplained chest, sternum, rib pain, I believe it's possible it might be coming from thoracic cause. I have pain there, thoracic spine issue. Yeah, so sometimes we'll use imaging of the thoracic spine to rule out thoracic spinal nerve roots that are being pressed or irritated. But we usually, again, we're going to treat and evaluate the whole person. So I always look at the thoracic spine if it's a problem and what we might need to do to treat it. Most of the time we're treating that in addition to the CCI. Munit, it's a sign of getting worse, was overall pain in the neck or something different. Munit, I didn't understand the last question. Rishi, what else can platelet lysate be used apart from treating nerve injuries? Platelet lysate can be used for lots of things. We tend to use it more around nerves, but it obviously can take the place of PRP. It can be mixed with things like a hypertonic solution to add more punch to Prolo, for example. Goose, how do you know if your symptoms are PPPD or from the neck? Maybe add a little more color to that. Brendan, Dr. Centeno, my provider, wants to provide a brain test, including brainwave testing, see if my neuro claims are accurate. Do you know if this detect issue is caused by the CCI? Probably not. Rishi, can you hydrodissect the auriculotemporal nerve? We can. Is the auriculotemporal nerve part of the trigeminal nerve? Not in the strictest sense, meaning we're going to hydrodissect back here. So the most common place the auriculotemporal nerve gets irritated is behind the mandible. And so that's not uncommon in patients that have TMJ issues. Rishi, can BMAC do everything PRP can do? The only difference is BMAC actually contains more healing cells. Pretty much. Rishi, when performing axial nerve hydro, I understand you inject at the root of the nerve, which would release the nerve from any compression. However, how can the platelet lysate travel further up the injured part of the nerve? For example, your nerve is further up the scalp. Yeah, we can treat the nerve in lots of different places where it can get irritated. It can get irritated as it's going through the suboccipital nerves. That's what we call a C2 car wash. It can get irritated, for instance, as the groin-occipital nerve comes out right along the upper trap. Normally, it's not getting irritated back in here because there's not much back in here to irritate it. Raymond, is the DMX the best first diagnosis tool for neurologic symptoms? Yeah, it's just again, I don't want to say it's the best, but it's just the one that's the most likely to show instability if it's present. My pain has moved from my 0-1 joint to my jawline. Oh, okay. Yeah, so again, probably just lots of overload of the TMJ, which is pretty common in CCI patients. So it may mean that the TMJ needs to be treated. Amika fan, don't forget to push like the button. Oh, sure. Yes, guys, push the like button. I'm pretty bad with that stuff. I see all the real experienced YouTubers saying subscribe, like, et cetera, et cetera. So I'll say that since this person brought it up, subscribe, like, et cetera. Risha, I read my procedure notes and there were comments such as BMAC injection, then chased with PRP, stent of the alar accessory, could be seen on the facet joints. Yeah, usually not chased with PRP as much as combined with PRP. So PRP is in all of our bone marrow concentrate procedures, as is platelet lysate. So it's bone marrow concentrate plus PRP plus platelet lysate. So those things are almost always done together. They're lifting restrictions. It's usually activity is tolerated, but we certainly don't want you moving a couch the next day. So what I mean by activity is tolerated is don't do things that you know are going to really irritate that area. However, if your pain returns back to normal pretty quickly and you know, for example, that I can usually do X and it doesn't flare me up, then you can go back to doing X. Boko Fanak, do you think dry needling is effective to heal damaged tissue? I think that if you're trying to dry needle a tendon, you can maybe heal the tendon. All you're really doing is causing bleeding within the tendon, so you could get there much quicker by doing a PRP shot, meaning that if all you're doing is causing bleeding in a tendon, you're only going to get 1x platelets. Now, in a young person, 1x platelets should be enough, but if you're talking about a middle-aged or older person, it's dramatically underdosing the tendon. You'd want to use anywhere from 5x to 15x concentration. So it wouldn't be the most effective way to treat a tendon in a middle-aged or older person, but if you've got a 25-year-old, dry needling can be very effective because you're releasing platelets and getting that area to bleed. But in a middle-aged or older person, it's a dramatic underdose of the problem. Valerie, if you've had severe flare and pain with prolotherapy, well, this indicates likely also out with PRP or BMC. Yeah, a lot depends on why you had the flare-up. But if you have a flare-up with all procedures, then we're going to put you in that fragile leg category where less is more, meaning less intensive injections first before we see how you respond. Now, sometimes people flare up from prolotherapy because it was done blind and it got injected in the wrong spot. And that's a different story altogether. Cheyenne, how do we determine if a patient can tolerate a large number of injections such as TMJ, posterior cervical, thoracic, and PICL? Yeah, that's based on hands-on physical exam, looking for the hallmark signs of central sensitization. So for example, if I examine a neck and I can barely touch the neck, then they're in that category where less is more, for example. Ryan, how was the trip to Grand Cayman? Oh, it was good. My family was down there. My last trip down to Grand Cayman. Yeah, it's always nice down there. I grew up in Florida, so it's not as big a deal to me. My kids grew up here in the mountains, so it's a bigger deal to them. But it was good. Teddy, how does your practice differ from Dr. Hauser's carrying medical? Do you agree on most things? Have you worked together? Super different from Dr. Hauser's practice. So Dr. Hauser would offer very simple ligament injections and usually without any guidance or with minimal guidance. So he's not going to do any of this more complex stuff we're talking about. Not going to be doing the 0-1 facet injections, 1-2 facet injections. Not going to be doing the PICL procedure. So, the big difference is just in levels of complexity. I think if all you need, so if you have the type of CCI, like a type 3A, that just needs a little prolotherapy in these ligaments back here, that's a good fit for that practice. Having said that, if you've got a type 2B where you see C1, C2 side to side or an atlantoaxial instability, not a good fit. That type of treatment, very simple ligament injections, is not going to help. So it's just a difference of expertise levels and a difference of sophistication levels in what can get injected. And so you have to match the type of CCI you have to the type of treatment you need. And like I said, if it's that 3A, then Hauser should be able to help you. If it's a 2B, not so much. Redo. Doctor, what do you do if you can't sleep at night because of pain? Should I use soft collar or semi-rigid one? Is there any problems that could occur sleeping with a collar? Yeah, I think if you're going to use a collar at night would be the best way to use it. Happy to help. And I think we're going to start wrapping this up now. I think I've been going for an hour and 10 minutes or so. Rhymes docs, as you mentioned, is quite risky to inject on the side. Does it mean your transverse ligaments require to inject from the back? Well, it's not the direction that you're injecting from. It's just staying out of the vertebral artery is the big deal. So if you're going to try to inject the cervical intertransverse ligaments, it would have to be done with fluoroscopy, contrast, and digital subtraction angiography. For example, we were just talking about a practice that does very simple ligament prolotherapy, that's going to be way over that capability. So that's a more complex thing. It can be done from the side, can be done from the back. You just need the right tools to do it and someone that knows how to use those tools. Otherwise, the risk of hurting the patient is much higher. Lemon, is there anyone in Texas that deals with instabilities or someone else in the country that your level of experience? No, big NO on that one. Pia, what concentration of PRP would you recommend for 18-year-old male for posterior? You don't need highly concentrated PRP. 2 to 4x should be just fine. Doctor, hope you're well. Is it possible one day you will train the people in the world in Europe to do the PICL treatment? I feel everyone needs access to life-changing treatment. I doubt Europe, to be honest with you. We generally have many fewer people there with levels of expertise that would be needed to train, and it's going to be much more expensive to train those people here, meaning they would have to come here for months, and I don't know many doctors that can take months out of a busy practice. It's just not very feasible. So I think Europe will probably be a no-go for quite some time. Okay, guys, I think I've gotten through all the questions. Thank you so much for all your great questions today. Again, here we learn by asking questions and getting answers to questions. There are no bad questions. The goal is to try to make sure that everyone gets much, much smarter about all this stuff so they can make good healthcare choices. Let's see, I will be here this coming Friday. So I look forward to seeing you then. We'll have another topic to talk about and do lots of Q&A. So you all have a fantastic weekend. It's nice and snowy here, so hopefully the snow melts super quick. You have a great time where you are. Thank you so much.